Hello, and thank you for joining us. Today is September 17th, and this is the first in a series of 3 presentations on newborn screening. This presentation and the MOC4 module on newborn screening communication is being presented as a collaborative multi-state project in conjunction with the University of Michigan Public Health Institute. We are joined today by Amy Glaviglio, who's the follow-up supervisor and genetic counselor with the Minnesota Department of Health. We will also have several parents on the lines to answer questions and answers at the end of this particular session. And with that, I'm going to turn it over to Amy to do the presentation on newborn screening and introduction. Amy, are you there? Amy, can you speak? All right, I'll unmute
The conference
the call.
has been unmuted.
Amy, are you able to join us?
Oh, yes. Can you hear me?
We can hear you now.
Okay, perfect. Thank you so much. So as a quick introduction, we do just need to mention that the creation of this module is funded through the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And so this module will provide an overview of newborn screening, particularly in the United States. Next slide. So the learning objectives for this module are, 1, to understand the current state of newborn screening processes in the U.S. and recognize that variations do exist between individual state screening programs. The second objective is to appreciate the differences between screening and diagnostic tests. And the final objective is to identify resources related to newborn screening geared towards both healthcare providers as well as patients and families. Next slide. So it is important for us to begin the module by clarifying that the totality of newborn screening is made up of 3 distinct types of screens: the blood spot portion, hearing screening, and the use of pulse oximetry to detect critical congenital heart disease. And while the focus of this and the following presentations in this MOC4 series are very largely geared towards the blood spot screening segment, both hearing and pulse oximetry screening will be touched on briefly later in this presentation. Next slide. So this slide presents 4 key points that will serve as a brief background on newborn screening programs. The first is that newborn screening is considered a public health program.
Hello.
The conference has been unmuted.
Can you still hear me, Kathy?
Now I can, yes.
Okay. At what point did you stop hearing me?
I think you're after the second bullet point.
Okay. Robust newborn screening programs do rely on the knowledge of numerous stakeholders, especially primary care providers, in order to successfully meet the goal of identifying and treating affected infants as soon as possible. Additionally, each state governs its own newborn screening program, which means that variations do exist from state to state, and healthcare providers should become familiar with the screening process in the state or states in which they practice. Newborn screening programs are also considered opt-out programs in nearly all states. This means that while the default is for newborn screening to occur without overt informed consent, parents may refuse or opt out of receiving screening on their child's behalf. And finally, a key tenet of newborn screening is that the disorders screened for must meet certain criteria, including, and perhaps most critically, that the disorder has an effective treatment available. Next slide.
Thank you. And if we could ask all the participants to mute their mics and mute their phones while the presentation is going on. We're still getting some feedback. Thank you.
So James Wilson and Gunnar Jungner first proposed criteria for population screening in a report commissioned by the World Health Organization in 1968. Interestingly, this report came out shortly after newborn screening for phenylketonuria, or PKU, was taking hold in the country. And though it's been actually exactly 50 years since this publication, and over 50 years since the advent of newborn screening for PKU.
Hey, I know. Good. How are you? Good. I'm running a little behind today. How's it going? Good. Oh my gosh. Oh.
If you could ask for the phones to be muted, please.
How's you doing? Great. Do you have any questions or concerns today?
All right. So I'll try it again to mute everyone, and then Amy.
I always ask you that. I wish there was before when I had paper.
The conference has been muted.
Amy, you should be able to speak now again.
Okay, can you hear me?
Yep.
Okay, perfect. So as I was saying, it's been either exactly or over 50 years since the publication of these criteria for population screening. The criteria are actually still very much used today to not only assess conditions for inclusion on newborn screening panels, but as well as for other population-based screening initiatives. Next slide. So the 10 criteria in the World Health Organization report are listed here. And to summarize, in order for a disorder to be considered appropriate for population-based screening, the disorder should be of clear medical consequence and have an effective treatment. Additionally, diagnostic and treatment centers should be available, and the natural history of the disorder should be understood and have a recognizable latent stage. From a screening perspective, a suitable test should exist that allows detection of at-risk individuals, and the cost of the screening program should be analyzed. Next slide. We're going to ask you if you can quickly complete this poll before moving on to the next slide, just to get some baseline data.
All right. So it looks like, again, the majority are providing communication on newborn screening at their clinic and hospitals to parents.
Perfect. Okay, so we've talked a little bit about the criteria that disorders must meet for inclusion in population-based screening, but let's look at the characteristics of screening tests in general and how they compare or contrast to diagnostic tests. So this table shows some key differences between screening and diagnostic tests. As you can see, screening tests are typically offered to a large non-symptomatic population, and as a result are really only able to provide an estimate of the level of risk an individual has of being affected. Thus, a positive or abnormal screening result will indicate whether a diagnostic test is subsequently needed. Because screening tests are trying to identify infants at risk of a serious but treatable disorder, the focus of screening tests is much more on the sensitivity of the test. That is, identifying all truly affected individuals. To do so typically means, though, that the specificity of screening is usually lower. So a proportion of individuals with a positive screen will ultimately be found to be unaffected, and the test result will be considered a false positive. In contrast, diagnostic tests are aimed at a targeted population where there is already some indication of the presence of disease, either through clinical symptoms or by a positive or abnormal screening test. So the purpose of a diagnostic test is to provide more or less definitive diagnosis, which means that diagnostic tests have higher specificity than screening tests. That means that diagnostic tests have lower rates of false positives and false negatives and more accurately identify those with and without disease. Next slide. So after newborn screening for PKU became established in the 1960s, newborn screening programs continued a slow but constant expansion by adding conditions such as congenital hypothyroidism, galactosemia, and sickle cell disease. And as a result, by the end of the 1990s or so, newborn screening programs were screening for a handful of disorders. Expansion of newborn screening programs really hit a boom, however, in the early 2000s, largely with the introduction of a technology called Tandem mass spectrometry that allowed programs to multiplex and screen for numerous disorders using the same small blood spot. And certainly, while the application of this new technology led to the ability to screen for many more disorders quickly and cheaply, it also led to some pretty wide-ranging disparities between state programs in terms of how many disorders were being screened for state to state. So in 2006, in an effort to provide uniformity to state programs, the American College of Medical Genetics, as well as the Health Resources and Services Administration, identified a list of disorders for which all state screening programs should screen. This group also outlined a process of standardization and evaluation guidelines for future additions to state screening panels. The list of disorders recommended at the federal level for inclusion on state newborn screening panels is known as the RUSP, or the Recommended Uniform Screening Panel. It's important to note that the R in RUSP stands for recommended and not required, which means that each state program still independently chooses whether they will screen for the disorder or not. And disorders are added currently to the RUSP after thoughtful consideration of a host of criteria, again, largely based on the previously mentioned Wilson and Youngner criteria. Next slide. So this slide illustrates the steps needed for a disorder to be included on the RUSP. So to begin, a disorder must be nominated and a nomination package submitted that includes but is not limited to information on the natural history of the disorder, treatment effectiveness, and the availability of a suitable screening test. The nomination package is then sent to a nomination and prioritization work group that assesses whether the disorder seems to meet the screening criteria. If the full committee votes to continue the process based on the review by this work group, the disorder then moves to the larger scale evidence review work group. This group does a exceedingly thorough literature search of the disorder, as well as conducts interviews with condition-specific and public health experts. The evidence review work group is given 9 months to complete their analysis and present their findings back to the full committee. At this time, the full committee votes on whether or not they will recommend the disorder for inclusion on the RUSP. The full committee's recommendation for inclusion to the RUSP is sent to the Secretary of Health and Human Services, who has the ultimate authority to add the disorder or not to the RUSP. And the Secretary is given 180 days to make this final determination. Next slide. So this table serves as a reference for conditions that are currently included on the federal RUSP. And I know this is a bit of a busy slide, so the key takeaway messages from this table are, one, so looking at prevalence, while we can see that the disorders included are fairly individually rare when looking at kind of birth prevalence individually. But taken together, they are actually really quite common. In fact, over 12,500 newborns are diagnosed in the U.S. each year with one of the conditions detected through newborn screening. The second takeaway is that there's a range of severity of the disorders screened for by newborn screening. And programs typically define disorders as either being time critical or time sensitive. So time critical disorders are those that may present acutely in the immediate newborn period. And thus it's really important that newborn screening results are available for these disorders within 5 days of birth. Those conditions deemed time sensitive tend not to present within the first week of life, and so it's recommended more that those results be available within 7 days of birth, so giving a little bit more time. And the third takeaway message is really looking at the last column, is the timeline for the addition of the various disorders to state screening panels. And as you can see, there is a range of dates provided for many of the disorders. So it's really helpful to familiarize yourself with the screening timeline for your particular state. Next slide. Okay, so while the previous slides focused on the formal process of adding conditions to the RUSP and illustrated those conditions that are formally on the RUSP, it needs to be noted that disorders may also be added at the state level through the legislative process. In fact, several state programs are screening for additional disorders as a result of state legislative mandates. Typically, these mandates are driven by family or disorder-specific advocates and often do not come with associated funding, which can result in some fairly significant delays in implementation of the screening program for that disorder. Next slide. So ultimately, it's important for clinicians to understand that newborn screening programs do remain state-based programs, which means that even in the context of the RUSP, state variations still exist. And from program to program, there may be variations in what disorders the program screened for. And again, this is largely going to be due to state-based decisions on whether to screen for disorders on the RUSP. It can be due to legislative mandates requiring screening for additional disorders, or due to differences in how disorders are actually added and implemented to a state's individual panel. In addition to which disorders are screened, there may also be variations in how the disorder is screened for between programs. So for example, in screening for congenital hypothyroidism, one state program may choose to look first at thyroid stimulating hormone or TSH levels, while another state may look first at thyroxine or T4 levels. And variations in testing methodology are seen in many of the disorders on newborn screening panels. And finally, it's important to note that differences may also exist before and after screening in terms of what options are available to parents around newborn screening. So parental options can include whether or not the family has the ability to refuse screening, for which reasons a family is allowed to refuse, or options around what happens to the blood spots after screening is completed. And several resources are listed here that can provide you with specific information about screening practices in your state. And additional provider and family-specific resources will also be presented at the end of the presentation. Next slide. So as was mentioned earlier on, a robust newborn screening program really relies on the coordinated interactions of a number of individuals, spanning a range of fields in order to successfully accomplish the goals of the program. And you, as a primary care provider, play a particularly pivotal role in ensuring screening results are documented, provided to, and understood by the patients in your practice. Next slide. Okay, so for the remainder of the presentation, we will actually walk through the newborn screening process in order to place your role as the primary care provider within the context of the newborn screening system. So as a reminder, newborn screening is currently composed of 3 different screens. The first 2 screens we'll talk about are considered point of care screens, as the screen and results are all available at the bedside. So newborn hearing screening uses an objective physiological test to examine the brain and ear's response to audio stimuli. The goal of newborn hearing screening is to detect hearing loss in the range where speech is heard in order to foster communication and linguistic development. Approximately 1 in 300 newborns is born with a congenital hearing loss in the United States. Pulse oximetry screening aims at detecting hypoxemia that may be indicative of a previously unrecognized critical congenital heart disease. Oxygen saturation measurements are taken about 24 hours of age in both the right hand, which is considered the pre-ductal measurement, as well as either foot, which is considered the post-ductal measurement. And around 1 in 500 newborns is born with a critical congenital heart defect, with up to 25% of those infants being missed if relying solely on clinical symptoms or prenatal sonograms. And finally, the blood spot portion is, without a doubt, the oldest of newborn screens and is typically the one that most physicians think of when they are thinking about newborn screening. And this portion analyzes a small amount of blood taken from the infant's heel shortly after birth. The blood is spotted onto special filter paper and sent to a public health laboratory for analysis. Next slide. This is a quick schematic of the pre-analytical portion of newborn blood spot screening. So prior to collecting the blood spots, all families should be provided information about newborn screening. Ideally, this information should be provided both in the prenatal period as well as in the immediate postnatal period and always prior to specimen collection. Nearly all state programs recommend that blood spot specimens for newborn screening be collected via heel stick between 24 and 48 hours of age. And the reason for this time period is that it enables a more representative analyte measurement while also allowing for early detection and treatment of affected infants. After the specimen is collected, blood spots should be allowed to dry in a horizontal position for at least 3 hours prior to being sent to the public health lab. In order to facilitate efficiency in newborn screening, all specimens should be sent to the screening program within 24 hours of collection. Next slide. Blood spot specimens will be tested as soon as possible upon receipt by the screening lab. There are several possible types of results that may be generated by the newborn screening program, and these are listed on this slide. For the purpose of this presentation, I will not review each potential result individually, as each of these results will actually be discussed in much more detail in future presentations. But this is just so that you can see there are generally 4 different types of results that may come out of newborn screening. Next slide. In general, newborn screening programs aim to have results available within 7 days of birth, and often positive or abnormal results will be available earlier. In the case of negative or normal results, screening programs will send the results back to the birth facility that submitted the blood spots. This includes if the birth facility is a licensed birth center or a midwifery practice. Some programs also send the report to the primary care provider, whereas others expect that the birth facility forward the report on to the primary care provider. But in either case, healthcare providers can also always request screening reports directly from the screening program. Positive or abnormal results are typically provided to both a primary care provider and an appropriate specialist via telephone by the newborn screening program. Most often, the screening program relies on either the primary care provider or the specialist to notify the family of the positive result and the need for further follow-up. Next slide. So without a doubt, the primary care team really plays the principal role in ensuring that screening results for all patients are available and documented. As mentioned on the previous slide, screening results really, regardless of type of results, should be available by the 2-week well-child visit and provided to the family at or by that visit. And in many cases, you as the primary care provider will be the first person that notifies the family with a positive or abnormal result. And in the case of normal results, you may be the only way parents receive the results and have a chance to ask any questions they may have about newborn screening. Next slide. So a few key points to consider when providing newborn screening results to parents is to understand that they may not remember having the newborn screen done or fully appreciate the purpose of newborn screening. This is especially common if the first time the family was introduced to the concept of newborn screening was shortly after delivery or even in that 24-hour period right before the specimen is collected. So because of this, many families have reported that they find it helpful to receive the results along with some context to the results. And while we'll discuss some communication strategies in more depth in future presentations, a couple of starting points are presented here. So the first is remind families what newborn screening is. In other words, it's a screen to identify whether the child is at risk for a defined list of treatable disorders. And also mention what it is not. So there often is misconceptions that newborn screening is drug testing or paternity testing. So just a reminder of what it is and isn't. The second key point is it's also helpful to note that newborn screening only provides a risk assessment and not a definitive diagnosis, as well as mentioning that it does not look for all possible disorders a child might have. Next slide. So this is also a really good time to talk a bit about terminology. And hopefully, kind of through the slides presented thus far, you've seen that newborn screening involves much more today than simply screening for PKU. And despite this, the term PKU test is still used regularly to describe the newborn screen. And while using the term or saying the term PKU test may seem like a totally benign thing to do, inappropriate terminology use actually has resulted in both healthcare provider confusion, family confusion, as well as the wrong follow-up clinical evaluation and our lab tests being drawn. So as a result of the potential and what we've seen, really tangible negative consequences of using the term PKU test, it is really recommended that any references to this term should be replaced with the term newborn screening. And that's whether it is said verbally, whether it's documented like that in the electronic medical record, or on any paper forms. Next slide. Because newborn screening has been around for decades, it can be easy to dismiss it as something that just happens, or to think, I'll hear about the results if something is wrong. But the expansion, in conjunction with the increasing complexity of newborn screening, really warrants a renewed commitment to newborn screening result communication. In supporting this assertion are results from a recent study that showed that almost 40% of parents surveyed in one state reported that they never received their newborn screening results. And perhaps more telling, nearly all those parents that were surveyed reported that they really wanted to receive their child's newborn screening results, even if everything was normal and okay. So thus, this module, as well as the subsequent presentations in this series, are really aimed at providing guidance and information in order to meet the new challenges in newborn screening and the desires of the families that the program serves. Next slide. So to end, shown here are several resources available to primary care providers outside of your state's newborn screening program website, which is also a great resource. But these can also help answer questions both on newborn screening processes as well as disorder-specific information. And you can see that some of the resources are geared both to providers and family, while others have more specific audiences. So the ACMG ACT sheets are much more disorder-specific and provider-specific, whereas STAR-G, for example, has much more family, kind of family-geared resources. So I think with that, we can open up to discussion and questions.
The conference has been unmuted.
I'm unmuting all lines. And first of all, I'd like to turn it over to Angie Thompson, a parent, with any observations that you have related to the communication in topic here.
Sure, thank you. I was just jotting down a few things as I was listening to the excellent presentation. So, this is really the first test that a parent's child is going to have, and it has obviously potentially significant implications for the child's health. So just to emphasize that it's really important for those parents to know whether it's positive or negative, what those results are, so they can be educated about their child's health. And also to know, what that positive and what that negative means for their child going forward. So, and if anybody has any questions for me, I'd be happy to answer them.
And also any questions for Amy, too.
So I had a question. What happens if the baby's premature and you need to get blood testing done? Are there differences in the timing of what you do or the kinds of tests that are done?
Yeah, that's a great question. And like anything, the recommendations will be state-specific. But I would say in general, most programs have what they call a low birth weight or NICU screening protocol, and what this typically means is that these infants usually get more than one routine newborn screen, typically up to 3. So each state is a little different on their recommendations for timing, but in general they'll get one at the normal time, so that 24 to 48 hours, usually maybe a couple weeks later, so around 14 days or so, and then again around a month or at discharge. And the concept behind this is certainly that preemies, it's kind of hard to get a handle of what's really going on with them from a biochemical perspective, and so looking at the screening results kind of over time gives us a better picture of what's actually going on in that child, and often helps reduce some of the false positive results we typically see in that population, specifically around the endocrine results. So it won't be uncommon as a primary care provider, if you're taking care of an ex-preemie or an ex-NICU baby, that you may actually see more than one screen result come across your desk.
Other questions? Are there any other parents on the line who'd want to be able to add observations from their perspectives?
Kathy, this is Matt Edick at Michigan Public Health Institute. But I'd like to add a perspective as a parent, not as a professional. I can think back to when my youngest child was born, and that was it was a really stressful time. He had some special medical needs, and I certainly don't recall having his test done or even receiving his results at any point. And as we were doing this work in the Midwest Genetics Network with Amy and several others on our work group, I was thinking back to my other child who was typically developed, and I also don't recall her having the test or getting the results. And so I just wanted to emphasize that, Amy, when you were talking about the tips for providers about making sure you provide the context and understand that parents may not remember that these things have been done, I think that's a really, really important point. I think it's hard to be receptive to that information if you don't remember it came. And later on, when we talk about positive screens and borderline screens, it becomes even more important to make sure you provide that context.
Yeah, thank you for kind of re-pointing that out or highlighting that. I do think it's important to provide context, and sometimes it can be as simple as, do you remember when your baby had a Band-Aid on the foot and they had that heel poke? Sometimes just kind of reminding them of those visual cues can put it into context and help them kind of shift between prenatal screening or other tests that are often done shortly after birth, kind of reminding them of the process of newborn screening. We've found that really helps parents understand the results and put it into some context of when it actually happened. So thank you for highlighting that.
Any other questions? Or if you want to type in a question at the chat box, you can do that also.
Amy, this is Chuck Ober from Minnesota. And could you speak just to why states are allowed to choose which ones they want to screen for, which disorders, and why there just isn't a federal system where there would be uniformity across the states? I know it's a little outside the scope, but...
Yeah, it's a great question. I think one that is asked quite often. My understanding of the reason that screening really has remained state-based is because the resources available to states are different. And so state programs may have different amount of funding allotted or available to their newborn screening programs. So depending on how the disorder needs to be tested for, they may simply not have the right equipment or the ability to procure the right equipment to do the testing. But I think what more and more what we're seeing in terms of hesitation to add disorders is really in that downstream, that post-analytical time. So how good is the test? How many false positives? Or, with the advent of molecular testing, how many variants of unknown significance will we be putting out into the community? And knowing that primary care providers are already quite burdened in patient load, and also knowing that our specialists, our genetic specialists, a lot of our pediatric specialists are quite burdened as well, just trying to be cognizant of the medical system. In addition, I think looking at treatment availability is also been something that states have struggled with. So one thing I said in terms of criteria is that a treatment needs to be available for the disorder, but I think what programs are concerned about is whether it's actually accessible to their population. So if it's something where the disorder requires a bone marrow transplant and there's only a few specialty centers in the country who feel comfortable transplanting those children, then that's a big burden on a mandated screen. So I think that's some of the hesitation comes from. So I would say in terms of why it's still state-based is still very much resource-driven. I know Dr. Sue Berry is on as well, and I don't know if she has anything to add to that question. It's a fantastic question.
It has. We want to think our medical care is uniform, and we want to have justice for all and so on. But the truth is, states still, in addition to the resources, Amy, value their states' rights to direct their local needs. Part of it has to do with resources available, and part of it has to do with how the state perceives their role in government as well. So it's a combination of things. I think one thing that Amy didn't even bring up, which is it may not apply to those who are on this particular set of MOC4 activities, but some states actually perform 2 screens as a standard strategy as well. And so there's a lot not entirely understood about all elements of what's the optimal way to screen. It's not necessarily bad that there's a general that people work on different methodologies, because eventually some of the best ones come to the surface. I'd also mention that the CDC, the Centers for Disease Control, the federal agency charged with surveillance of the public health, provides a lot of materials to make testing as uniform as possible and as reliable as possible to all states.
Well, those are both helpful answers. Just to follow up, that being said, about what percent are the states similar? Are we about 90% similar across all the conditions, or is it less than that?
So that's a really important question. Soon after the Recommended Uniform Screening Panel was created, it took not very much time for all of the states to agree to screen for all of the core conditions. And so the core conditions on the Recommended Uniform Screening Panel are performed by all states. The secondary conditions was more variable, and even now, not all states perform screening for all the so-called secondary conditions. And then you have some final diversity in states that have elected to add disorders by legislation. Some states have added disorders that are not on the Recommended Uniform Screening Panel, and in fact have been evaluated at the federal level and declined for screening. So if people are interested in sort of the spectrum of what states actually screen for, we could add that to one of the resources. The American Public Health Laboratories, working with HRSA, have a project that they refer to as New Steps, and it helps newborn screening programs achieve a uniform level of competence and expertise in newborn screening. And one of the things they have is some interactive maps that show you what your state does and what other states do in terms of screening. It's really an interesting thing to play with a little bit and just see what differences exist.
That's a good point. We can include in the follow-up the email to this session, a link to the various resources that were on the last slide that were provided. And then if there's a link to the resource that you just mentioned, Sue, we can include that then too. We also have a question here. Any recommendation on sharing borderline positive newborn screening results with families, knowing that the majority of these will be false positive?
This is Amy. I would say stay tuned for presentation 3, which will completely delve into exactly what that question is asking, how to communicate those results in balancing the risk for it to be a true positive, which in some cases that risk is quite high, with the understanding that false positives exist as well. So I would say make sure you tune into presentation 3.
Sounds good. We also
Amy,
have
this
several.
is Jim Maple-Lentz. Hello? I'm a
Hello?
pediatrician in Minnesota. Hey, this is Jim Maple-Lentz, pediatrician in Minnesota. I have a question just about how I get the timely newborn screen into my system. I'm on Epic currently. We have a website that we can go in and, as a clinic, log in and obtain the newborn screen. So we kind of got away from the fax route. But I was wondering, one is there seems to be a password that times out if nobody logs in. If I'm on vacation, I tend to be the one doing it. That it just kind of throws a loop in it for like the system here in our clinic. And what the reasoning may be behind that, and also if you could speak just in general to how different states might successfully do the newborn screen and push it into electronic medical record systems.
Yeah, that is a big question. So in terms of any type of portals for result reports, and I do think state programs are very much moving to this over faxing. It allows, in theory, clinics a little bit more flexibility in terms of getting the reports for patients in their practice, and also it's not uncommon for the primary care provider listed on the newborn screening card to not actually be the primary care provider of the child. So kind of allows, even in the absence of that knowledge by the program, allows the clinics to go in and grab results. In terms of password security, I can only speak to our experience in Minnesota, though. In talking with other state programs, I know it's similar. It's really all about result and data security, and so there are guidelines when you are looking at patient results or any portals that require private health or that include private health information for how often you have to rechange your password, especially at the government level. So that's kind of a stipulation in terms of patient privacy. Hopefully programs have something set up so that when the password expires, it's not exceedingly burdensome to reset the password. But I'd be happy to talk to you offline about that as it pertains specifically to Minnesota. In terms of actually electronic messaging the results to the electronic medical record, this is very much something that is a hot topic in newborn screening right now. Not only just getting demographic information, so kind of on the front end to come to us, but how can we push the results back both to the submitting facility and the clinic. So messaging to that degree with this many results, because many programs are screening for upwards of 60 disorders now, is a pretty large undertaking. However, I would say that it's something that nearly every program that I'm aware of is actively looking into how they can put that directly back into the EMR. So I think you will see it sooner than later.
See, we have another question here. It looks like another Minnesota pediatrician. We've gotten pushback from some hospitals They don't want to do the newborn screening when the patient needs a repeat if the baby was not born at the hospital. For example, a baby was born at hospital A but lives in area C, and the local lab is refusing to do the draw even though they have a nursery and do them every day. Any comments on that?
So this is in the context of a requested repeat?
Repeat. Mm-hmm.
I guess my suggestion would be to contact the state health program, the newborn screening program. So I can't remember, Kathy, if you said this one was from Minnesota. Mm-hmm. If so, you can contact me. And what we would do would be to reach out to that lab or that hospital, that facility, to inquire about why there's a refusal, if they're concerned about insurance reimbursement, or if they don't have specimen cards for some reason. So I guess my recommendation, and I think this would be largely true of any state, would be to let the state program know so that they can work with that facility and try to troubleshoot what the issue is. Obviously, we want to get those repeats in. We ask for them for a reason. So we would take it upon ourselves to help troubleshoot and figure out what the issue or barrier is.
Sounds good. What we'll include as a follow-up to this email is, first of all, will be the link to the recorded session. We'll include the resources that are identified. We'll include Amy's email, so questions like this for follow-up, that there'll be a place for that to go. And then also, as we look at the date for our second training session in October, we should have some more information on that too. I know tentatively they're looking at about October 22nd, again at lunchtime, but we'll get confirmation on that and send it out too. I'd like to be able to also answer questions that clinics are having related to their first baseline audit, and we have several questions that have come in on that, so I just want to do a follow-up. In terms of your baseline audit, right now we still do not have the American Academy of Pediatric KETA system online. There have been a few changes that have had to be made, and so that should be online shortly. So in the meantime, during the month of September, there's a form that you can fill out and just email it to me, and I'll enter it into the system for you. And then in the second audit, you'll be entering it into the system yourself. So I'll include a copy of that form. You don't go to the ABP website, and there's a special link for the AAP website for doing the data entry. So all of that we'll include as a follow-up email too. Other questions from clinics that have completed their baseline audit? Or other questions for Amy or Matt or parents? All right. Well, if there's no further questions, we will end the recording and give you back 10 extra minutes for your lunchtime here, so that this will also be available for you and archived, so that if other people within your group would like to listen to the presentation, you can also share that too. Any other wrap-up comments from Matt, Amy, or parents?
I just want to say thank you to everybody for attending, and thank you very much, Amy and Sue, for all the work that you guys put into this presentation. And I'm not sure how many of our workgroup members are on, but thanks to all of them as well. Really excited to see this rolling out, and I hope everybody is enjoying it so far, and I think you're going to find it increasingly informative as we go through the next two presentations. So thank you.
Thank you very much. And we do have close to 80 people, 80 pediatricians signed up across 8 states that are participating. And on the line today, we've got about 30 on audio and 30 on the web-based system. So we will send a link for those that are not participating so they can listen at their leisure. So with that, thank you so much. Enjoy the rest of your week.